Good afternoon, everyone, and thank you for joining us for our community conversations on healthcare. We're excited to have the opportunity to share with you some of the great things that are happening in healthcare, both in this community and in the province. My name is Nancy McConnell-Maxner. I work with Nova Scotia Health, and I'm your moderator for this afternoon, not this evening. I trust you had an opportunity to visit the tables out front, find a little bit out about virtual care in Nova Scotia, emergency health services, and primary care, emergency care, and had a chance to sign up for a COVID vaccine or the Get a Family Practice list. So there was lots of conversation out there, and it's always hard to bring people back when they're having good conversation, but we know that a lot of what we're here for today is for our questions and answers with our health leadership team. So for the next part of the afternoon, we are going to hear from our health leadership. You're going to have an opportunity to ask some questions. There were some cards that were handed out when you came in, and you either can write those if you have questions that you want to ask yourself. You can do that. We have roving mics that will go around the room, and you can just put your hand up, and I'll just look out for hands that are up, and a microphone will be brought to you, so you don't have to get up, and you can read your question. If you don't want to read your question yourself, you can pass it along to one of the roving mic people, and they'll bring it to me, and I will read it on your behalf. So we also have some pre-submitted questions. We are going to try to get the people that are here your questions answered first. And if it's quiet and nobody has questions, then we'll go to the submitted questions and make sure we have those answered for you. I will also say to you that if we don't get to you, and it's busy, and I know that Minister Thompson does have a commitment, and we have to be out of here at 4 o'clock, so we commit to that as well. But if we don't get to your questions, write them on your card with your contact information, and I can promise you that someone will get back in touch with you. We've had a number of these events, and sometimes we go a little long because it gets lots of questions and answers, but you will hear back. So rest assured, if you don't get your question tonight, you will get an answer at some point in the future. I do also want to mention that this is being recorded. This part of the event is being recorded so that anyone who wants to see it and isn't able to join this afternoon can watch it virtually. And I think that's it for me right now. I'm going to pass it over now to Angela Simmons, the MLA for Preston.
Thank you. Thank you, Nancy, and welcome everyone. It's so exciting to be here. First, I'd like to acknowledge that we are on Mi'kma'ki, the ancestral and unceded territory of the Mi'kmaq people. And I also further wish to acknowledge that the peoples of African descent are among the founding settled people in this province and have contributed since the early 1604, socially, culturally, and professionally. And I offer my gratitude and privilege and stand on the shoulders of my ancestors and want to take the time to acknowledge that. So thank you, everyone who is here for that. And also, I'm thrilled to be part of this afternoon's conversation. I think this is a really great moment here that we're on the stage together. This is how politics and changes are made, is when we work together. So I'm excited and thrilled to be able to be here this afternoon with conversations with all of you and our health leaders. So it's important. I'm pleased to welcome the Health and Wellness Minister, Michelle Thompson, and the Nova Scotia interim CEO, Karen Oldfield. And they'll provide an update on the work that's underway to improve the healthcare system from your questions and what they've been learning. And also the Health and Wellness Deputy Minister, Jeannine Lagassé, is also here with us this afternoon to help address the questions. And again, I want to thank everyone for being here and appreciate your time. And now I will turn this over to Minister Thompson. Welcome. Okay, does anyone, you're good? Okay.
Yeah, thank you, Angela, very much. It's nice to be on this side together.
Yeah.
So good afternoon, everyone. My name is Michelle Thompson. I am the MLA for Antigonish and also the Minister of Health and Wellness and the Minister responsible for the Office of Healthcare Professional Recruitment. And it's really an honor for me to be here today with my colleagues to come out and talk about what's happening in healthcare. So we did run on a platform of healthcare, and certainly that was a message that resonated with Nova Scotians, and we have been working very hard around the healthcare file over the last 15 months. And I wanted to come out with the leadership team. We wanted to be present in community to let you know what some of the things are that are happening behind the scenes in regards to healthcare, but also to hear from you directly. Not only experiences, but most importantly around solutions. So we began our mandate by going across the province and hearing from healthcare workers directly. And we traveled from Neils Harbor to Yarmouth and all points in between over a 4-day period, the Premier and I and the health leadership team. And we heard about the challenges that were facing healthcare workers, but we also heard from them directly around the things that they felt we could do or that had to be done in order to transform our healthcare system. And so from that information that we gathered from healthcare workers, we wrote a plan called the Action for Health, and it's the first health plan that we've had in the province for at least a dozen years. And there's 6 pillars, and it talks about some of the actions. It's not fully inclusive. We know that we're going to have to change over the period of the next several years, but it does outline what we heard specifically. There's also a website called Action for Health, and it's a website that tells you how we're doing in terms of progress. So we have the objectives, we have our, where we want to go and how we're performing against those objectives. And some of it is going well, and some of it is a bit more of a struggle, but we want to be transparent about that. We want to let you know that there are challenges that we haven't cracked the nut yet, but there are other things that we are able to advance. So we've had about 15 months, and we know that we have significant human resource challenges. We know we need more healthcare workers in our province, and we'll talk a little bit about some of our efforts. And we need to increase capacity and grow our own workforce, but we know that immigration is going to be a key component to bring the healthcare workers we need. Not just doctors and nurses, we talk about them all the time, but we need lab technologists and diagnostic imaging, and we need social workers and all the range of healthcare workers to support us. So today we want to talk a little bit about what we've been up to, and I want to acknowledge and recognize that there has been a disparity in the health in our province for a very long time historically, and we know that people of African descent have not had the same privilege and the same health care that others of us have. And so we want to talk about that today, and we want to look at the barriers. We want to look at where we can improve and how we can improve, and we want to hear from you directly about things that we can do better and differently in order to make sure that we have a more equitable healthcare system in Nova Scotia. So I look forward to hearing from you, your comments, your solutions, your expectations, and I look forward to sharing with you some of the early work that we've started in the first 15 months. So thank you for coming, and thanks for having us.
Good afternoon, everyone. It is our real pleasure to be here this afternoon. This is our 6th stop on our tour, our conversations tour. We were in Sheet Harbour last night, had a great conversation. I know that Mr. Hensby was there with us there last night. He's here again today, which is great to see. And I just want to tell you that, as the minister said, we want to talk about the work that we've been doing, but really we're here to hear from you, because as you ask questions, as we tell you what we can to answer your questions, we learn something every time from every community and about your community in particular. And so we really are very, very interested in hearing from you. We want this to be a conversation back and forth, that we aren't going to do a long presentation, really just introducing ourselves and saying that we want to do that. And just thank you very much for inviting us into your community and for attending today.
Hi, everyone. I'm Karen Oldfield. I am
There we go. Might make it a bit easier. My name is Karen Oldfield. I am the interim CEO at Nova Scotia Health. It's been a very interesting 15 months since September 1, 2021 for me. We've learned a lot over the past 6 sessions. So we started off, we've been to, just so you know, Windsor, Truro, Antigonish. We had a lovely Monday night at the Halifax Forum this week, and Sheet Harbour, and then today. So we have, today marks 1/3, because we have 18 altogether, which we'll finish up just before Christmas, I think. And, every community is a little bit different, and it's as Jeannine says, we learn, we tweak, we learn. I spoke to a couple of folks just before we started, and you know, by background, by the way, I am a lawyer, and those were the good old days. But one expression that was taught to me by one of my mentors very early in my own career was that nothing good can ever be forced. And it just stuck with me for my entire career, which now is like getting up around 35 years. And so that is kind of how I approach most of the work that I do, no matter what sector. And so I really believe in collaboration. I believe in hearing, in listening, and then trying to take what you learn in a community or in a sector, and then apply it to get to the best outcome. So that's really what we're interested in, and I look forward to the conversation today. Thanks for having us.
Okay, thank you. And just wanted to mention that we do have our masks off when we're on the mics, because it's really hard to hear with them on. So, and we're trying to stay far enough back from you so that we're following safety protocols. So I think what I'd like to do is just bring it back to the audience, and to say, if anyone has a question, you can put your hand up. I'm going to stand back here so I can see, hopefully, whoever puts their hand up, and if we've got multiple people, we'll just count people off to go. So, okay, over here we have a question. I said it the other night, I said I feel like an auctioneer, and I also apologize for the pointing, because I know we're not really supposed to point, right, but I'm not sure how else to do it. So, yep, right here. Yep, thank you.
There we go. Good afternoon. This question has been brought up before. It's more of a concern and a point, and I think it needs to be reiterated. But how will you ensure that your senior leadership is reflective of the communities in which it serves? It has been brought up many times that there is no African Nova Scotian or Mi'kmaq representation at the senior level making decisions for health. And I don't want to speak for everybody, but I think it is still a very big concern of the community. And so I think that needs to be addressed, and it is a priority issue. Thank you.
Thank you for that question. So for those folks that don't know, the day after we formed government, one of the actions that we took was to dissolve the board, the Nova Scotia Health Authority Board. And we did, and there was African Nova Scotian representative there, as well as a First Nation representative there. So we took that action because at this time in the healthcare crisis, we felt that we needed an agile decision-making team. And so currently, the Nova Scotia Health interim CEO, Deputy Minister Lagassé, Dr. Kevin Oldfield, and Janet Davidson sit as an administrative team, the health leadership team. And for the first time, make decisions as the policymaker and funder and the operator. And so we recognize that the team is not diverse, and we continue to work through this agile team and understand how best to collaborate. So for me as the Minister of Health, it's important that we maintain relationships with diverse communities. And I would say we have not figured out what the new structure will look like going forward. So we do have a good relationship with Dutch-Agamic. So Dutch-Agamic is a First Nation health, I don't think it's an authority, but a health community. And so we work with them around supporting and planning health initiatives that are specific to First Nation communities. We are also work in partnership with a Health Association of African Canadians, and we do have, we are working now on a health equity framework. We appreciate that it's a gap. There is now health equity framework, which I think folks can speak to who are on that committee rather than me representing their work. to look at how we are more equitable in terms of the delivery, in terms of the strategic direction, in terms of understanding the needs of underrepresented communities, and how we increase representation and safety in the healthcare system. So I think there are folks that can better articulate some of the work that's happening, but thank you for raising that. And to your point, we know that it's a gap, and we continue to move towards a resolution, and I appreciate that it's not perfect yet, but we are committed to improving.
I'd like to add something to it, though, because the minister's spoken about in particular, the health leadership team and, governance going forward. I also think that, this is the Nova Scotia Health Authority in Nova Scotia has between 26 and 30,000 people, depending on who you include and how it's counted. And I would actually add to the point that you have made, because I think there's a lot of room to ensure that our diversity and inclusion efforts are not just at the senior levels, but we need to identify people and help them and develop their pathway to manager level, to director level, to executive director level, and so forth. I mean, it's not just at the top, it's all the way up and across our organization. So that's certainly something that I've recognized, and that, we've really started to put quite an effort to improve. So I'll just add that as well.
Oxlow, and I am speaking on behalf of the Black Nurses Association of Nova Scotia this afternoon. This is the hat that I'm wearing. People who know me know I wear many hats, but I want to be very clear which hat I'm wearing. So in addition to the question about representation at the senior level, I want to take it to the system level, whereby nurses are providing service delivery to the communities, to Nova Scotian communities, regardless whether they're black, white, or whatever the color. Representation is an issue. Many black nurses will tell you they find themselves as the only black nurse on the unit working. Now, I can attest to this because I have lived that, but I know this was 30, 40 years ago, and that was okay, but we're in 2022 today. So representation at the system level, at the care level is important. And so for many reasons, when I go into the hospital, it'll be lovely to see somebody who looks like me, because at that time I'm in need, and that's not there. So my question is, how are we going to increase representation, given the fact that we are on the bandwagon for the EDI, which is equity, diversity, and inclusion? How are we going to do that? But it's not only a token gesture of including representation. What are we going to do to create safe spaces so that nurses can practice without the feeling of racism, microaggression, and those things that they experience? So therefore, they cannot perform to the fullest, they cannot thrive or strive and give safe care. So my question is, how are we going to rectify this?
So I'll start. These are some of the things that and I'm certainly open to solutions, certainly from all of you. So I think it's really important that we start in the school system, in the education system, supporting people from underrepresented groups, whichever that group is, and we start recognizing those folks who have an affinity to this work, right? To affinity for healthcare. And I will tell you, and I've said it in all the sessions, there is so much opportunity in healthcare in our province right now, in every community, whether you want to be a physician or you want to be a nurse or a social worker, anything at all, there's just so much opportunity, and it's such a good opportunity for us as a generation up from beginning our careers to keep young people in Nova Scotia. So if there's a young person in your life or mid-level career, please encourage them to come into healthcare. I know we hear a lot of negative things, but there are a lot of good things too. And so we want to start working with youth. We need to work with our partners in education to help identify and support people. And that's at the elementary and high school level. It's very important as well that we work with our academic institutions to ensure that we have designated seats so that there is a clear pathway for folks from underrepresented communities to be able to find a clear pathway. So there are a number of things that have happened. There are some seats designated through Dal Medicine. There are some nursing seats, and there's recently a cohort for social workers of African Nova Scotian descent to make sure that we can improve designation or representation across the healthcare system, because that's the key. Breaking down the barriers and understanding what they are, removing them, and ensuring that people have a pathway. And then when they enter the workforce, making sure that there are clear expectations, not only of colleagues, but also of patients. We talked about it a little bit. In the beginning of the pandemic, healthcare workers were seen as heroes, and certainly over the last couple of years, as frustration has mounted, we have seen that healthcare workers have been targeted, and I know that healthcare workers of color have been targeted as well. So we need to strengthen those policies with clear actions and reactions. When we find people in our system that don't do well, it is going to take some time. We need to do education. People need to learn to self-reflect, and they need to understand their own bias. And some of the work has to happen internally, but we have to call people to do that. We have to ask them, and we need to give them the supports to do that. So I don't think there's one thing. I think there's a number of things, and we need to be talking to people about their lived experience and what are the things that would make those folks feel safer in their workplace. And so it's going to take some time, but every single thing we do is a step towards progress. But I don't have the lived experience. And so if there are things that you feel, anyone here feels that we can do differently or better, it's very important that we hear.
Thank you, Minister Thompson. We have a question over here, and then I'll get, so one and then two.
Thank you. I'm glad that we're having this forum today, and it's very timely. I have been a healthcare provider for 43 years, and I retired in 2020, just at the height of the pandemic. Yay. But anyway, I'd just like to, because I've been the recipient of very, very unfair practices during my career, racist comments, racist actions from managers, supervisors, co-workers, and so it's been kind of a life of trauma throughout my career, and which I've had to process on my own. But I'm wondering, does Nova Scotia Health have, I know you have a program for diversity and inclusion and all of that, but is there a mandate in specific workplaces to have cultural competence teaching and make that a requirement of every healthcare facility that is in this province? Because what happens is that if you're recruiting nurses of African descent, doctors of African descent, any healthcare provider of African descent, what happens is that the microaggression, the treatment, which is less, it's horrendous. How do you feel people are going to be maintained and retained as a result, of the treatment that it comes from the system? And so, what I am wondering is there, a mandate to ensure that there is cultural competence teaching and training provided for people who are working within the system? I just think it's crucial. It's an important piece, and I'd like to see it happen. The organization that I work with at the latter part of my career, that's one of the things that we did on a regular basis. We had cultural competence training, and it needed to happen again and again and again. But it's important if we're going to talk about inclusion in the healthcare of Nova Scotians, African Nova Scotian and Indigenous, diverse communities. If we're going to be talking about that, then we got to make sure that we have some training to allow those in mainstream to have an understanding and know what to do and what not to do and what to say and what not to say. I think that's all I have to say on that. Yes, thank you.
Okay, Jeannine wants to talk about the department and I'll talk about Nova Scotia Health. So, excellent point. And, I guess that kind of goes back to what I was starting to say at the outset. 26,000 people, employees at Nova Scotia Health, and we don't, for the most part, we have to do a better job of having those employees reflect our community across the province. So we've done several things. There can always be more, and that is one thing I guess that I'm very interested in hearing, whether here today in a group or personally. And I'll just say, any healthcare worker in the room that wants to talk to me separately about any issue, I'm happy to hear about it. Sometimes it's harder to raise it in a group setting. So I'll just talk about what I've done. Early in my own time at Nova Scotia Health, and partially because of the fact that our board was disbanded, I did reach out, had a number of sessions, some with employees, our Nova Scotia Health employees from African Nova Scotian background and Black Canadian background. Learned some things, also met with members of the community, learned some things, stepped back from that and tried to figure out what was the best path forward. One of the outcomes, recently, I think maybe within the last 8 weeks, we retained the help of Professor David Devine. I don't know if he would be known to some of you. So he's working with us to help us to kind of plot the path forward, in part to make sure that we're training, developing those who currently work at Nova Scotia Health and beyond to create these safe spaces that have been talked about. I worry a lot that we don't know what we don't know. And you've talked about 43 years of your own career and the trauma that you experienced, and I don't know how we get all of that and surface all of that, address it, and move on. It is a monumental task, and so I worry that we just don't do enough. I worry that we pay lip service. I worry that we're not digging deep enough. And so I really come to learn as much as to say we're doing this and we're doing that. And we are doing things. We're doing things. But I would worry that it's not enough. That's what I worry. And I really believe that education is a big part of it, for sure. But I think that we have to find ways and career paths for members of our diverse communities to be holding leadership positions so that they can, advance, mentor, develop, help. And so we just need to do more. That's what I would say to that. And so I am all ears. We've started, we're focused, but it's, still iffy, I guess, hit and miss.
So in the department in 2021, we created a new division within our department, the Equity and Engagement Division, and it's led by John Ario, who's our executive director there. And really, we've undertaken a number of different initiatives since the branch has been created. But really, it is about engagement out in the community, and that there's a lot of work that they are doing in that regard to hear from community as we move forward to create the health equity framework that is required under the new anti-racism legislation by next July 2023, we're required. So they're working with community. They're also working within our department, because I think that and we're working with the Nova Scotia Health Authority, with the IWK, with our partners at EHS, because we're all on this journey together, but we've never really worked in that way before as a system. So John has convened the equity lead folks from the health authorities to work with him and his group to advance equity, diversity, inclusion on a system level, to make sure that we're all talking about it and doing the right things that the community are asking for, and working with community. So one of the things that we've done in the department, to the minister's point about we need to get out earlier and we need to get into the schools and we need to be talking with students, is that over the last 2 years, we've had 8 African Nova Scotian students who were either just finishing high school or starting university to come to work in the department for the summer as part of the Black Youth Mentorship Program that the province operates in a number of different departments. And what we're hoping for those students is that they will see health as a career, either within the department or at one of our health authority partners. So we're hoping to be able to next year maybe rotate them through a few different places so that they can get some different experiences. So to Karen's point, those are just a few of the few of the things that we've started to do. We can do more, we know we can do better, and we must do better for all of you.
Thank you. Oh.
So thank you, Rose, for sharing those painful thoughts. We've had many conversations over the many years about that. So, and thank you for the work that you're doing with regards to looking at ways to move forward to address that. But I'll tell you, as a nurse who's been practicing for who practiced for almost 48 years, I will tell you education is important, but this is about values and beliefs, okay? This is about the values and beliefs that are instilled in us and how we see and how we view people. And so on one level, I can give you all the education and all the training you want, but if I haven't reflected and emptied myself of those privilege, racism, ideas, and better than attitude, nothing happens. And I'm saying this as a psychiatric mental health nurse. So I think we have to look at what we're doing from a training perspective, but come from the lens to say it is not about education and training. It is about touching the core of the being. Otherwise, it's the same old, same old. So therefore, I know David very well, we have to look at how we do things differently. We have to do things with the inclusion of the people who have experienced it. The lived experience, the people, we can tell and teach and guide many things. And so I support education and awareness, but education and awareness has not cut it. It will not cut it if we don't take a different lens of being involved in the reflective process of the values and belief that we all have within us.
Thank you, Josephine, for that. I agree. I think it's very important that we teach people how to self-reflect. Not everybody has that skill, and education is the first part, but we do have to guide people through a self-reflective process, a critical self-reflective process. And for those regulated professionals in particular, it will need to be mandatory. It's part of what we do as regulated professionals. We do critical self-reflection on a number of areas, and this has to be part of it, right? Equity, diversity, and inclusion, and understanding bias and how we show up. And so I think the work needs to deepen. I think we're here and we need to go deeper, and we are committed to that. We probably will not get it right every time, but I do want to assure you that this is important. This is our opportunity and we want to do it. We want to do it right, and we will continue to work, and we continue to get feedback, and we want to hear when we don't get it right, because that's what has to happen, and we need to do it with community, all diverse communities, all abilities, in order for us to make sure that that it's safe to receive care, but it's safe to give care as well.
Thank you. We have a question here, and then Armel Leismans.
Thank you for coming here today. I'm a citizen of Dartmouth, and I'm also involved in federal politics, and I know that there's 5.8 million Canadians across Canada who do not have a physician, and over 110,000 here who do not. I hear the people in this community, it sounds like they need a liaison within your system, and also the Indigenous people also need a liaison so that we can understand the needs of those specific communities. I also work with physicians who come from other countries, and physicians who've had high points in immigration, and people who are dermatologists who've worked for 21 years in other countries, and they come here and they're asked to recertify for many, many years. And I think there needs to be a change. I was in the dental field, in the implant field for 18 years, and I saw people coming from all different, from Africa, from Eastern Europe, coming and having to spend high amounts of dollars to recertify. And I think there needs to be a program that changes where, you know, there's find out what they know, do an oral exam, do a job shadowing, do a practical exam, and then do the written exam to find out how qualified these people are, because some of them are more qualified than our doctors.
Yeah, so I'll start and folks can fill in. So earlier we talked about the necessity of us to bring healthcare workers through immigration pathways, and we need to work with labor skills and immigration to make sure that we have the right streams, to make sure that it's easier for people to come here, particularly because we have such a gap. But to your point, we have been working very hard with the colleges. So the College of Physicians and Surgeons and the College of Registered Nurses, the College of Nurses, as two examples. Because to your point, people are trained in other places, they come here, and then there's barriers. So we needed to understand what some of those barriers were around education attainment. So there is some work that's happening around competency-based assessments. So rather than just purely looking at education requirements, whether your residency is 1 year or 2 years, or what, like, you know, all these little idiosyncrasies with each different country, looking actually at your competencies. And, you know, what are you able to do, and where is the gap, and how do we bridge the gap? So that's one thing. And looking at practice-ready assessments, so bringing particularly physicians in, they work in concert with another physician, and they're assessed, and then they move to a second physician, and that physician assesses them as well before they enter practice. And sometimes you can work on a defined license, which is just a little bit different, but it still allows you to use, you know, the fullness of your scope. So that is happening, it's underway, and we've seen some good progress with that. There are some healthcare providers in other places that maybe won't reach the fullness of their credentialing in a previous country, but they still have experience that's meaningful and important to our system. And so we are working with folks around a clinical associate role, clinical assistant role, so that physicians who are trained, internationally educated graduates, work with a physician under their kind of supervision, more or less, but at the same time able to practice to almost the fullness of their scope as well. So there is a lot of work underway. We recognize that there is a lot of capacity in the province already, working with nurses. And then if there are people, we're also looking at how do we work with immigration and refugees to bring people in here, bring them to a place where they can work in healthcare, because there's so many opportunities, and so maybe entering the profession as a CCA and laddering over time to an LPN and to a registered nurse. So there's been a lot of work happening about how we can work with immigration as well as foreign trained physicians and nurses. Yes. Yeah, we're very much targeting immigration. We're looking at places initially that are a little bit easier. So where are there some already pre-existing pathways? So India is one of the countries that we're looking at, the Philippines, and doing some work in North Africa with the Shapiro Foundation around folks who've indicated that they want to move to Canada. They've recognized that as their country of choice, and actually supporting by doing some pre-entry, like entry to Canada or entry to Nova Scotia in the home country, so that we can start, instead of waiting till you get here to start your education, how do we reach into the country of origin to start the education, and so it shortens the timeline from the time you signal that you want to come to Canada, the time you actually can be employed. So there's been some really good work started with that.
I just want to add to that. I mean, that makes a lot of sense, and to me, you know, finding the countries where we can quickly develop a partnership and where individuals want to come to Canada as the country of choice. And so, as the minister just said, it's so much easier for a healthcare worker to remain in their country of origin, come up to speed, and then come to Canada so that they can start working, as opposed to come to Canada, not be able to get a job, end up working in an area that's, you know, different from their skill set, and then get frustrated, demotivated, and just not realize, you know, what the dream that they set out to have. So we're kind of doing it in reverse. And that to me makes a lot of sense. And the other thing I would, you know, just add, so, you know, you mentioned about immigration, and this is a topic that has come up at most of our sessions to date. And just a few thoughts. You know, I have our numbers here. I just got to find it so I don't tell you the wrong number. But it's our nursing grads right now in Nova Scotia, I'm just focusing on nursing as an example. We've got 1,660 odd vacancies. Like, that's a lot of vacancies. And it's actually 25.7%. It's a big vacancy rate. And when we look at filling that, let's just look at Nova Scotia universities as an example. So we've got Dalhousie, we have Santa Fe, and we have CBU. That each of those universities are producing nursing grads. And right now, the seats in the graduating class, it's like 478. We've worked to increase the seats, and we've worked to increase the seats for LPNs as well. So starting this September, the class that will go in and will come out the other end will be like close to 1,000 between the RNs and the LPNs. But if you just take that number, and then so that's sort of 2 years away for the LPN, 4 years away for the RN. We think about retirements, we think about maternity leaves, paternity leaves, other leaves of absence, and so forth. We can't produce enough people to fill the vacancies that we have in as quick an order as we need it. So we do look to forming partnerships with other countries, with other universities. Like, for example, I had an email last week from Dr. Sani, the president of Dalhousie University. They just came back from a very successful trip to India, where they furthered partnerships with 3 different healthcare universities in India, and he's fairly confident that they've secured an additional pipeline of between 75 and 100 nurses per year. So that's helpful. It's still not enough. So, you know, we've encouraged every university president to do that. We're helping them, we're supporting them, and I'm just choosing nurses, but we could pick any number of healthcare workers, including physicians, and we do the same thing with respect to physicians. So it's an all hands on deck. We've got a lot of work to do, but it's interesting because the other part of this is ensuring that our providers are able to work to their, what we call the full scope of practice. So if we have any provider that, it could be pigeonholing, it could be regulatory, there could be any number of reasons why they're not able to be working to their full scope of practice. So where they could be doing this, they're only doing this. And when you think of all the people in the chain, so it's a CCA, it's an LPN, it's an RN, you know, it's an OT, it's a PT, it's a pharmacist, and so forth. If they're all working to full scope, then that chain looks like this. If they're not working to full scope, then it means you need more people. So we're working as fast as we can to make sure that folks are working to scope. And I'll just give you an example. A question that came in, I don't think it was in today's group of questions, but we had a question last week about a person needed to get a tetanus shot. So couldn't get in to see the family doctor, went to a number of pharmacies, went to a couple of walk-in clinics, and just like wasn't able to easily find a spot. Spent 9 hours going around to find a place, and then ended up actually at the mobile clinic on the weekend, and you know, was in and out in an hour. Okay, so that's the background. So you know, I come to work on Monday and I say, there's got to be a better way. You probably got this already, Natalie, and I'm sorry if you did, because I'm on the warpath on the tetanus shot. Like, that should be easy. You should not have to necessarily, you know, go to the physician for that. So where we can find another way to do it that's appropriate, that's what we need to do. Sorry, I just covered a lot of territory there. So probably lots more questions coming out of that.
Actually, we have, did Angela had, John? Sorry. Oh, sorry. Okay.
Good afternoon. My name is Jeannine Sujabulu. I work with Nova Scotia Health. And I thank you for the CEO for what you just said about immigration and nurses. I want to speak on behalf of the international nurses, internationally trained nurses that are already present here. There are hundreds of them who are already here and need to join the workforce. But they are still stuck as CCA because the pathway through the college is so tight. It takes forever for NNAS to do your assessment. And after that, you have to meander through the process of the college before you can even get authorization. And the news we're hearing is that some other provinces have kind of liberalized the process and made it easier for nurses to attempt NCLEX as soon as they can, so that they easily join the workforce. For example, Ontario and New Brunswick. And working on ground in VG, I can tell you that some of those nurses who have been frustrated by the college are looking elsewhere. Is there a way that you can liaise with the college to simplify this system so that these people who are already here, getting frustrated, not getting anywhere with the college, can join the workforce as soon as possible? Thank you.
Thank you for that. Yeah. And we have been working with the college. We've been very clear that we need them to go harder and faster, is what I would say. There has been some gains made. And then I think there are folks that, you know, once you get out of practice for a period of time and you're working at a different capacity than maybe you were trained for, sometimes you can, I mean, I don't know, but I think you can lose your courage a little bit. I'm a registered nurse as well, and I'd be hard pressed to go back now. I need a pretty strong orientation. So we want to make sure that folks can see that ladder. So if they do, if, you know, people come in as a continuing care assistant, then they quickly see that there is opportunity for LPN as well as registered nurse, particularly if they're registered nurses in their home country. So there's more work to do. We're trying to learn from other provinces. We don't need to reinvent the wheel. I'm just wondering a way that they could signal if they're working as continuing care assistant.
So this is one of the issues, is identifying people. So please don't run away today before we, you know, get the email, because I'm just going to give you an example of how one pathway opened up. Not too long ago, I was at Fisherman's Memorial Hospital in Lunenburg, and we were touring the facility, and I just asked if somebody could take a picture. So anyway, I walked down the hall to find somebody to take the picture, and there was a young fellow, and he had his name tag, Jojo, RN. And so I asked Jojo if he would take the picture, no problem. So I got chatting, and he came to Canada from India, and he is a graduate of the University of Kerala. And I asked him, how easy was the path? He says, well, I've been a nurse here for 10 years. My path was relatively easy, but I have at least 10 friends in Bridgewater from my university who are, having a challenge, Karen. And I said, okay, take the picture, give me your email. He took the picture. I did get his email, and now he's working with us, part-time. He's still a nurse at Fisherman, but he's also helping us as a navigator with his classmates and other people across Canada who graduated from the University of Kerala. So, that was an innocent crossing of paths, but I'm telling you, this is very helpful because people know people. And people are the best way to bring their friends and their other classmates and so forth into the workforce. So we've actually, from that, we've developed a survey that was sent out through iSANS. I'm not sure all of the groups that sent out the survey, but basically trying to look for associations that can through this survey, help us to identify people. So it could be a survey that could go out through your association if it hasn't already. So through the survey, we've identified 278 nurses from who are currently in the province who would need some help to ladder or do this or that or the other thing. So there's not just one thing, it's many things, and that was kind of almost by happenstance. So but I'll take it any which way, because we really need to find the people, and there's no reason, none, that there can't be some job for a trained healthcare professional, okay? It may not be their exact job that they train for. They may need time to get from A to B, but with the vacancies that we have, there is no reason a person cannot have a job at Nova Scotia Health, and that's a fact.
Thank you. I'm just going to count off so that we know who's going to. We have question here, then there, and then the back. So 1, 2, 3, 4. Okay. So she's 1, 2. She's 3. She's 3, 4. So I think those are the 4 right now. If there's anybody else, 5. Okay, 5.
And I'll be quick.
Okay.
I'll be quick. Thanks for being here. I never met the deputy or the CEO before, but Minister Thompson, I think to your point about lived experience matters, and so I just need to go back to Miss Rose and to my sister who spoke about the entrenched racism that exists within the healthcare. There's implicit bias that happens, and I'll speak for myself and my children when we visit the hospital. So I do believe that in terms of asking us to be continuously patient, we have been patient, and there should be some not only accountability but consequence when someone interacts with racism. There is an implicit bias, in particular for Black folks, when they go into the hospital, in particular the emergency room. One example which I shared with Ms. Minister Thompson, implicit bias of how people are treated. That cannot continue. If you do continue to engage with people but don't do the work where it's necessary, we are just going to spiral. And I just want to really just make the comment too about retention. If people are not feeling welcomed and continuously face racism, and I'm speaking about racism because when you lump Black Canadians or African Nova Scotians and Indigenous into equity-seeking communities, it changes the narrative. There should be a specific plan, equity plan. I know Dr. Devine well, but to my sister's point, lived experiences, you cannot talk about a profession. We can tell you what racism looks like and how it feels. We do not need a professional in a capacity in healthcare to tell us that. What you need is a person who can talk about racism and how it impacts and how we're going to change within systems. And I speak to that as someone who did consultant work with the IWK. The mentality that some of these professionals and healthcare workers have entrenched about Black people is a problem. An entrenched problem that I really hope that under senior leadership that you evaluate and bring people to the table. The Brotherhood and the Sisterhood and Hawk are doing amazing things. It is not on the backs of them that they do this work. And so I'm hopeful that there's going to be some changes, but I speak here as a mother of 3 Black children and 2 grandchildren, as someone who grew up in Cherry Brook, lives in North Preston, and has encountered racism daily, that it needs to be addressed and not just acknowledged, but a plan. And so I just need to say that.
Thank you for that. Thank you. I think, so I'm gonna just speak from my heart, and I hope it's okay. I think the important role of the consultant is that as we move through this time and space together to do better, that the responsibility, we need the lived experience, and we need to understand, and to your point, it's our responsibility too. And so trying to find the balance so that it's not fully your responsibility to tell me and teach me and show me a better way, that we have someone who is paid and who can create that path so that it's not all on the community all of the time to tell us. And I don't know if I'm saying that properly, but we're trying to find the balance so that it's not your responsibility to teach me how to be different and better at my job. And so I want that lived experience, and we want to hear it, and we want that person to be paid and to bring their value and help us do better for you so that you don't have to do that all the time. And I don't know exactly what the balance is, but that is the hope and the intention, and I think we need to keep trying to figure out how to do it together, if that's appropriate. Yeah.
I think what CEO spoke about was well, in terms of finding someone in a student, and then you bring the student in to help you. So I just hope that with those conversations that the leadership learns, right? And so it's again, he's teaching, but are we learning? So I now am mindful of other people, so I'm just saying I appreciate it, and the work that's being done.
But, just to be clear, that's just one, David is one person. He's only one aspect. Like, there are many. It's many. So, and no, yeah, but I certainly don't want to, have bad things about David, because he's helping, but only in an area, right? An area. So, yeah. 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 Okay, I think we're having a violent agreement. We're having a violent agreement, so I violently agree with you. Thank you.
Okay, thank you.
Thanks,
I know we have a
Angela.
question right here, and then we know here, here, and here. So they're
Hi there. My name's Rob Groom. I'm a paramedic here in Central for the better part of 15 years. I'll apologize beforehand. I'm not a great public speaker, so excuse me stumbling on my words. I want to speak specifically about paramedic retainment, and it translates to other healthcare workers, but it's unique for paramedics. And I'll preface it with the experience that I've had over the last 2 years, and be cognizant that I'm one paramedic out of 12 to 1,300, so you can probably duplicate similar experiences across the board. At the beginning of the pandemic, when the news coming out of Italy and New York was paramedics, nurses, and physicians dying daily, I had one of the first exposures to COVID in the healthcare setting. I went home from that shift, or didn't go home. I went to a hotel to check into for 2 nights, so my elderly father-in-law could move into our part of the house so I could do the rest of my self-isolation in his apartment. Nobody reached out in any meaningful way in my leadership to kind of check in on that situation. And I never saw any remuneration for the out-of-pocket costs for the hotel or any of that. Fast forward to a few weeks later, the Northwood crisis happened, and I was part of the team that went in there. we were in egregious, appalling conditions for quite a while. Nobody from that team got so much as a thank you email. Then in October of 2021, one of our colleagues had a health crisis. Her family were not local. I was the only one available that actually knew her personally to be at her bedside when they withdrew care. I was on shift. As soon as they withdrew care and we said goodbye and she passed, I went right back to work. So I want to kind of preface all that with the culture that exists in the provider of paramedics and how they treat their people. It's with a dispassionate indifference. So how do you guys plan on addressing the culture that exists with EMC? And how does that translate into retaining paramedics or recruiting more paramedics? Because I'm a fairly well-regarded paramedic locally. I'm not a troublemaker. Like, I don't have any issues at my workplace. But the culture of how they treat people is deplorable. It's got nothing even to do with wages. So is that on your guys' radar, and how do you plan to address it? Thank you.
Yeah. Thank you. So I'm going to start, and then I'll get my colleague Jeff Fraser. Yeah. So paramedics are. We worry about paramedics. I worry about paramedics. I'm a former emergency room nurse, and have a deep appreciation for my paramedic colleagues. We've been working very closely with the company. We have a committee that has the company, the union, Department of Health, Nova Scotia Health, and your college of paramedics to look at the challenges that the paramedics are facing right now. We also know that there are a number of paramedics. There's vacancies, but there's also a number of paramedics who are off sick, right? There's a lot, and we know that. And so our role is as a regulator in the paramedics. So we've made some gains. There's a lot to do, is what I would say. I don't know, Jeff, if there's anything you want to add, but I do want to assure you that we are worried about paramedics. We are working very closely with the company that the concerns of paramedics are heard. We have a good working relationship, more or less, with the union, and we are trying to make improvements that are lasting, not just in terms of your day-to-day work, like shift overruns, like those types of things, the long, particularly when you're in rural and you need to, when you're pulled for coverage for extended periods of time, offloads, those day-to-day things that are really difficult. But in terms of your long-term wellness and the culture of the profession.
Yeah, so I've been doing it for 15 years, and the buzzwords are around mental health and supporting folks. My gosh, there's been a load of lip service, but when it, it just doesn't translate into any meaningful action, and the onus is on the individual paramedic to self-identify when they're struggling or they need trouble for supports. These are not things that it should be a leap for a leader to recognize. That individual just went through some stuff. We need to kind of go in and support them without them self-identifying, because there's a stigma around that, and it just doesn't exist within fire, police, nursing are very well supported by each other. I just don't quite understand how it's acceptable for the provider that provides paramedics right now to be let to continue how they're operating. And I'm really keen to see what sort of strategic plan you guys are going to put in place to address this.
Yeah, so there's probably a couple of things that we can talk to you about offline. I too worry about first responders, and a number of our, not only paramedics, but a lot of our firefighters are volunteer, right? And so the impact that has, and I worked in Emerge for a number of years, but I didn't see, the scene. And it was difficult enough in the role that I had. So I think if there's things that you think could be different, it would be really helpful to hear from you directly, and I think maybe we could chat about it afterwards.
I'll just say one
think the the minister's right, and let me just back up. So, for those who don't know, the province has a contract with EMC. So, this is one of the things we run into all the time, too. So, we don't directly employ the paramedics, meaning Nova Scotia Health does not directly employ the paramedics. They work for EMC. So, I don't tell you what to do. I'm not your employer. And so many little things come about as a result of that. So there's like the right hand is not talking to the left hand when it comes to the connection between ambulances, paramedics coming into a hospital, like as an example, and you can speak to it and Jeff can too. So you have your IT system, you have your information system, and you have what you have, okay, come into the hospital, and I have what I have, and it's not the same thing. So all of a sudden, it's time wasted. So, all your stats are on your particular computer software, and that's not, you can't just upload or download. We don't talk to each other. So can you imagine how much time, extra time that takes? So there are many operational challenges that come about as a result of the fact that ambulance services they're not under my control. So what we have to do is find ways to work together, and I guess that's where I was coming. So what we've tried to do really hard is to bring EMC into the loop, so to speak, so that they're not off on their own, doing their own thing, that they're part of what we're trying to do, part of the goals and objectives that we're trying to set, so strategic. And, staffing is one of them. So we are very concerned about that, and you've put your finger on something that's really scary to us because we don't directly employ, but we need everybody to be healthy and treated properly. Like I've written down what you said about the thank you notes. I mean, that's not how I roll, but I can't help the fact that happened. It's not necessarily the way it should. It's cultural, but we have I have my own issues on the culture side of the house. So we need to try to find the ways to be on the same page. It's not really a great answer to your question, but it is the fact of it. And so we do know that we have to find the ways to integrate as opposed to silo.
Very well versed on the challenges that exist within patient flow from the health authority. And I think that, folks have this idea that it's a nursing shortage at the emergency department level. And really, a lot of the hiccups are with off-service beds or patients that are consulted to a service and services are using the emergency department inappropriately as their holding area, bottlenecking access to care that are in the waiting room or ambulance stretchers. So what's the impetus to change that?
Where would we start? Yeah. So I'll just tell you, it's on. So part of the issue is getting out of the hospital, first of all, making sure that there's an outflow, right? So that's, when we talk about access and flow, it's not just coming in and coming to the emergency room, but actually how do we make sure that you get the care that you need in a timely fashion, that there's nothing non-medical that keeps you in that bed for any period of time, and then the outflow as well. So we do have seniors in long-term care, really trying to maximize the beds in the province, because there are people who are in hospital who are waiting for a long-term care bed or home care. So really working very hard to support our colleagues. So one of the things that was really important for us to do was increase the wages of continuing care assistants. There was a huge number of vacancies in the province, and there continues to still be, but that number is reducing regularly. And I can tell you, I worked in long-term care before I was elected, and there was like the local community college had less than 10 graduates on an annual basis in order for folks to come in and work in long-term care for continuing care assistants. And that was for long-term care, community care, everywhere. So we have over 1,000 people registered in the continuing care program this year, which is really significant. That's a big number, and they're working to support them moving through the system. That helps us because there are beds closed in the province because long-term care facilities are not fully staffed and they can't safely take patients, residents to move there. So also nursing homes are now training their own. So that's part of it. We also have C3 that Karen can talk to a little bit, and it is looking at the whole system and understanding where the capacity is and moving people through in a very meaningful way. And that C3, it's a command center, and it's staffed by frontline clinicians who can look and see what's happening in all of the different areas in order to move people through and make timely decisions with real-time data, not yesterday, not an hour, not so that people can see in real time what's happening in order to support people and move them through. So staffing is very important. We have to look at processes. It's not one answer, but I can assure you there's a number of things going on, and the work that's happening around seniors and long-term care is really important because it helps move people out of the hospital, which is what we need. So, like as an example, people could wait in hospital for 10 days because they need a grab bar put in their home. So why wouldn't we have a carpenter on the discharge team, right? So you have an occupational therapist, a social worker, and a handy person, like a carpenter or whatever, who can go in and quickly do that, and there's 4 or 5 bed days. So every little thing has to be looked at really critically to understand where the barriers are, and we're kind of open to anything. Like we kind of are open. We're testing and trying all kinds of different things, and where it works, we scale it up. So I just want to assure people that getting in is one thing, but it's really important in order for us to get in as patients. We may need to make sure people can get out as well. So,
Thank you. Oh, I think we're going to have, just because we have 3 more people that have questions and we're going to be out of time. So what I'm going to say is that if anybody else, we know we have the 3 outstanding questions. If anyone else has a burning questions, make sure you write it down on your card with your contact information so that someone can get back to you. So, sorry, and I just cut Jeff off altogether, so he's not, sorry, Jeff. I know, sorry. So actually there's a woman in the black and white top. I think she was next, and then you were next, and then you were next.
Thank you very much. I'm Daphne. I'm also a registered nurse. I am the president of United African Canadian Women's Association. So today I'm going to speak on behalf of the African community. And I want to know, because we talk about diversity and inclusion. And personally, I believe that there is no inclusion without diversity. So I think the first lady that asked the question, how are we represented? When we go to the hospital, because that's what I get all the time, if they don't see their kind, it's very hard for them to accept the care. So COVID-19 came, and we realized what happened. So how are we going to correct that system? I was thinking, is there a pathway for Black nurses, or not even nurses, because we do have a lot of school dropouts, we do have a lot of immigrants, we do have a lot of refugees that are there, that would like to enter the workforce, that wants to do nursing. Is there a pathway they can create for them to encourage them to be part of the workforce? That is 1. 2, you do have a lot of nurses, African nurses, that are in the workforce. So when you look at management, how many of them are there? How many? You see, because if we are not there to represent ourselves, you cannot talk for us. It is not possible. We can go through all kinds of training. If you're the only Black nurse in the entire unit, it's not going to change. We need to see and feel our presence. We need to be supported. Talking about the School of Nursing, how many Black tutors are there? To understand the children, to understand the students. So they need that. And that's what's going to change the situation. Thank you.
I think we need to start in the schools and work our way through and make those pathways easier. And representation is going to come through education and immigration, and that is the plan in a nutshell. But we have to make sure those pathways are easy.
Thank you.
No, no. Yeah, yeah. Yeah. So, yeah, so we're working with North Africa specifically, working with the Shapiro Foundation to support immigration. Like it's not just those countries; those are places where we have easier pathways. Anybody that can come to us, we're trying to establish those pathways. So if you have colleagues that will come and work here, then we want to talk to you. Whatever makes it easiest for us and you to bring folks in, that's exactly what we need. We need to start working with folks in their training when they're internationally educated to bring them here. We want them here. Yeah. So I'm happy to hear about your experience and where you trained and how you can help us bring more folks. Like that's exactly why we're here. Yep. Yeah.
Oh, hi. My name is Edward Jones, and I am a community member. Thank you for having us here this afternoon. And respectfully, I just find that too much politics has been played with healthcare. And it shouldn't be politics. It shouldn't be the next party that comes in power. That's the platform that you campaign on so that, then you get elected, and then when you go, the next one comes with a different agenda, right? So, because people's lives, people are dying, people are suffering. I go to my doctor now, I feel like I'm on an assembly line. 10 minutes, 5-10 minutes, and they want to push you out of the room to see the next person. So I think there's a lot of talk, but there has to be like deliberate, concrete actions taken. We've been talking about immigration for a long time. We want Nova Scotia to grow. Why hasn't the government planned for these things and create these pathways, put them in place before all this immigration? Now, that's why there are so many people without doctors, without family physicians. These things should have been in place long before all the immigration streams open, because now people are really struggling for doctors. So that is just what I had in my mind. Thank you so much for putting yourself in the bullseye and coming here. We appreciate it. But I think that policies have to change. Policies have to change, and it's very simple. Change the policy that is right for the people. It is not about politics. Respectfully, thank you very much.
Okay.
You start, and I'll get my thoughts together.
So in the minister's opening comments, she talked a bit about Action for Health, our plan for the health system. And I think it's intended to do exactly what you raised there. So we know we need to show some action quickly, that people need to see action now on some of these things. But what we really need to do is transform our system, because that's the only way that we're going to have long-term gain on this. So we have a short game to play and we have a long game to play. And so that's where, respectfully, you take the politics out of it, is working to transform the system. It's not going to happen this year, and it's not going to happen next year. This is a long-term thing. But if we keep going down the road that we're going, that is our hope and that is our goal, is that we will get to a place where we have a world-class health system, where we don't have the one-time involvement that takes us off that course. So I hope that helps answer a bit.
Yeah, and I will say too, when we look, healthcare is important because you can look at standards, right? We can look at what the standards are, what the outcomes are. When we look at national standards, they're irrefutable. irrefutable. They're beyond politics. And, you know, I get it. I'm a politician. This is my first crack at it. I was only elected in 2021. And I don't know what my future is. I'm employable. I'm a nurse. I hear we need a few in the province. So, you know, yeah, there's a job for me. So I ran because of healthcare. I've been in healthcare a long time, and I have to watch that it's not my blind spot, too, because I've been in it so long. But this is the thing. We need to set it on a trajectory that as all of these politicians change, there's a ready, responsive, and reliable healthcare system that underpins for Nova Scotians. And I'm thrilled that it's us that gets to transform the healthcare system, but at the same time, it has to go into perpetuity. It can't handle an electoral cycle. I agree completely, yeah.
I think you should share your story, Minister.
Zero. None. I couldn't get a job. I worked as a continuing care assistant for a year, and I worked as a recreation director for a year, and then I pieced jobs together. It's hard to believe in 25 years that can happen. And then I went away to Scotland for 4 years while my husband trained, and then when I came back, I got a job. So and then I had a whole bunch of babies. Not a whole lot. It felt like a lot, but three really short period of time. So, you know, it took me 10 years to get a permanent full-time job as a registered nurse. So that's 20 years ago. It's pretty amazing how things have changed in that period of time.
And I guess that's my point. Because, you know, she shut me off. You know, 20 years ago, this was totally foreseeable. Totally foreseeable. Okay? Study after study after study. So that was then, and this is now. Okay? Unfortunately, this is where we're at. So I just want to, I asked for these numbers yesterday because I just wanted to kind of see where we were. Physician retirement. Are there any physicians here? I didn't, one? Oh, Christy's in the back? Oh, of course. Forgot. So you guys can speak to this much better than I can. But here's the numbers I pulled. In 2019, 2020, so this would have been, I guess, front end of the pandemic, and perhaps this number is not surprising. There were 23 physician retirements in Nova Scotia. There were 8 in 2021 and 4. It sounds low to me, but anyway. Here's the point I was going to make, and the physicians can speak to this much better than I can. As we recruit physicians into the province and into Nova Scotia Health, doctors are working differently. So whereas my doctor might have, 4,000 patients, that's not really the way it works today. Physicians who are coming out of medical school, they want to work in collaborative practices in a team environment where they can share. And so what we had and the family doc of the past is not necessarily going to be the family doc of tomorrow. So in my head, I equate this, like if a physician retires, and in my head I think, okay, we need 3 to replace. So I'm basically looking at it 3 to 1, okay? Only because if, a 1,500 versus a 4,500 panel size is kind of more what the expectation is. So that means we have to really ramp up our recruitment efforts because it's not 1 for 1. Am I somewhere in the ballpark here, guys? If I'm off track, just say, please. So it's different. And then what happened in Nova Scotia, we had like the perfect storm because we had the retirements, and then we have an influx of immigration. So it's like a 2-shot swing if you play golf. So, more people and fewer providers. So now we're a little bit behind the 8 ball having to catch up. And the good news here, because there is good news, like I don't want to dwell on only bad. The good news here is in July 2023, Dalhousie University will graduate the biggest number of family practice graduates in the history of Dalhousie Medical School. So the efforts are working, okay? It just takes a long time to produce a doctor. Anything that either of you want to add to that? You don't feel compelled, but you. Oh, she's the next question. Okay.
I just wanted to introduce myself. I'm Dr. Natalie Chang, and I'm the medical site lead for Dartmouth General. So thank you for coming here and speaking to the work around, especially around the equity, diversity, and inclusion. I just wanted to add some of the work that we're doing locally. So I know you're looking for action, right? Just to say, I've long had an interest and a passion in equity work. I recently did a course through the Doctors Nova Scotia that focused, it was a project focusing specifically on improving diversity in physician leadership. And so that's kind of one start on the path. But I just wanted to say, we know that this community, Nova Scotia has one of the largest historic Black communities in Canada, right? We have this huge historical population. A lot of it comes to Dartmouth General. And I just wanted to say, you have an ally. I know a lot of the struggles, a lot of the privileges that you have been hard fought on the backs of your ancestors, on the backs of the struggles of those before you. But I want you to know that you're not alone, and that we are fighting with you at Dartmouth General in our leadership. We have recently formed a committee for the health promotion of African Nova Scotians. And that committee comprises several people, several amazing, inspiring leaders from your community. So for an example, Sharon Davis Murdoch recently got the Order of Canada for her work in equity. And then there is Rhonda Atwell, who is also, those two are the co-presidents of the Health Association of African Canadians. We have Ron Milne from the Brotherhood, who's on our committee. We have Chad Williams, who is the physician lead for internal medicine at Dartmouth General. And our focus of this committee is to look at how we can promote health amongst African Nova Scotians. And we're looking at cultural competency, we're looking at diversity in our health force. So I would love for you to pick up this pamphlet. It's sitting there on the desk. It talks about all sorts of initiatives that we have already started. So you're looking for action. We're looking at initiatives at every level. So we have the PLANS initiative, which is promoting leadership for African Nova Scotian students. These are high school students. We're looking at mentorship opportunities and career counseling for those who are interested in careers in health, because they're going to come back and improve the health in their own communities, right? Then we have scholarships that are specifically dedicated to African Nova Scotians, high school students that are seeking careers in healthcare. Then we have, we're 2/3 of the way towards planning, I would say, towards a job fair that is aimed specifically at those of African descent. So both African Nova Scotians and also newcomers, to improve the diversity in our hospital, because we know that if you see someone that looks like you, you're more likely to feel that your needs will be understood, that you will have someone that can help you navigate through the system. We recently sponsored 5 or 6 people to the International Black Health Conference, which is the first in Canada of its kind, looking at standard of care or things that will help improve the health. So I just wanted to know, we're working with you. There's now an affinity group that is being formed at Dartmouth General of staff and physicians who work at Dartmouth General at every level of our system, so that if you come to Dartmouth General, there will be a safe place for you to be able to talk to people who look like you, have mentorship opportunities, and we want you in our hospital. There are so many impressive, inspirational people in your community that I've met and had the honor to meet over the last several months or a year and a half that I've been in leadership, and I really look forward to working with you more. So thank you.
Somebody down here with a question, another question. Thank you very much. I don't know if you have a response. I don't know if you wanted to respond to that, or I don't know. I feel like it was
we're
like
lucky to have Natalie. Thank you, Dr. Chung. We're lucky to have you, and really appreciate the fact that you came today. And thanks for speaking
Thank
up
you.
to share. Thank you.
Okay, I have someone over here and then over here.
And the pamphlet, and she's a good salesperson too.
So I know we've been talking a lot about education and the need to recruit early, and I just want to bring a reality check in about that. And this is a personal story from a family member who wanted to be a nurse, always wanted to be a nurse. Got to high school and was told by their biology teacher they didn't think they were smart enough, and was actively blocked by that biology teacher from getting the grades that they needed in order to get into nursing. 6 weeks ago, finally graduated as an LPN, but it should not be that hard. It took them a decade. It shouldn't be that hard with all of those barriers. So we have to be very aware of exactly what is happening, because that is the reality of what's happening.
Thank you. We have another question. Another question here. Thank you for that.
My name is Crystal Mulder. I'm a resident of Lake Louise Cherry Brook and a healthcare consumer, for starters. As a ninth generation African Nova Scotian, I understand what my sister over here said about the school system and how it keeps our kids from pursuing careers in the health professions. Now, I hear that you've hired a consultant in Dr. David Devine, and that's lovely. One problem. Dr. David Devine does not have 400 years of living in Nova Scotia and putting up with the lived experiences that we've had to deal with racism when it comes to making decisions and recommendations around diversity and inclusion. And what he's making is recommendations. You don't have to take them if you don't want to. What we need are people around. I want to know why there are no professional healthcare workers around your table at leadership, at the ministerial level, making inroads and making sure that your diversity and inclusion plans address the needs of African Nova Scotians, period. Particularly those of us who have been here 400 years. It shouldn't take another 400 years for us to be heard. That is unacceptable in this day and age. That is unacceptable, period, since this province was built on our backs. And let's be very clear. This province was built on our backs. So you all got some serious, serious work to do. A consultant who is not from here, doesn't understand our community, is not the way to go. Here you have experience right here. 40 years of service, but she couldn't be asked? We had to ask somebody who has a PhD behind his name? She's got a PhD in being African Nova Scotian. I'll tell you that straight up. I got a PhD in being African Nova Scotian. We need to be at that table, not somebody from outside of us. And that's all I need to say.
Thank you for sharing that. I appreciate it.
Another question here. Did you say? Okay, yeah, that's what I thought. She's holding the baby at the same time, so I wasn't sure if it was.
So I have a question. I'm a nurse, also at Dartmouth General, work alongside Dr. Natalie Chang. Right now at Dartmouth General, obviously, there's a big problem with retention. So what are we doing about that? I've also worked with or know people who, in the Valley, for instance, there's travel nurses that they call, that are filling all these positions, and there's nurses leaving our units to go work for these companies. They're leaving NSHA, they're going and working for these companies because they're paying them more. They're paying their accommodation, they're paying for travel. Why am I gonna stay with your company, NSHA, when I could go make more money, which I need in this province to live and pay for our children and all these things when there's these companies that are taking over our hospital, not taking over, but we need them, not saying that we don't need them. It's just, what are we doing with retention? We need to focus on the nurses, all the staff who are there now, who have given this company years and years of service, and we're not getting anything. We're not getting thank you cards. We're not getting emails. We're not getting a Christmas gift. We're working so hard every day in these conditions, and we're not being told how we're going to be retained, or if there's an incentive for staying and not going for these Select Health and all these other companies out there. So that was my question. Comment.
Sure, and I appreciate that. I think that I worry about particularly younger nurses, particularly those who don't have young children, which may potentially keep them here because of grandparents, say, or family. I worry about my niece, who's a nurse, second year. Every other day, Karen, New Brunswick's paying this much more, Newfoundland's paying this much more. I can go travel nurse, I can go anywhere in the world, I can go on a cruise ship. What are you doing for me? Okay? Oh yeah. So I understand the issue 100%. And so, retention, we haven't really talked about it that much. I think retention is one of our biggest issues. And it's not all about the money. A lot of it is a nurse will work 12 hours, go home, feed kids, walk a dog, come back to work. And many healthcare workers are in the same boat. It's not just nurses, but nurses in particular. And so there has to be we have to find ways to improve the lifestyle, to improve the quality of life. And so just as an example, and I kind of look at paramedics, frankly, in the same way. Like, you can't just do 12 hours of heavy lifting all the time, every day. So, we had the opportunity to go to Denmark to learn about their system at the end of June. And one of the things, there were many things that impressed us, but one of the things I took note of, I've been starting to bang the table. I'm going to get to your answer here, but banging the table is with their paramedics, they have gone to rotations. So odd job might consist of 3 or 4 different rotations. Okay, so you're not on the truck all the time. Maybe part of it's in the ER, part of it might be on the 811 line or 911 line or what have you. So basically, dividing a job into 3 or 4 rotations, so maybe it's a week here, a week here, a week here, or however that's scheduled. So you get some, let's call it easy work, if there is such a thing. I look at nursing the same way. Like, I don't think it's right that some nurses, and no nurse is on easy street, but some jobs are easier than others. And so we have to find the ways to give you relief during your day. It could be during the day, it could be during a month. So that's something that we're really looking at. Of course, the single biggest challenge to that is that we have to work our way through a collective agreement, because those have been in place for a long, long time. And so, but I think everybody would be on the same side in improving work-life balance. So that's really high on the agenda, and providing those supports and helping you to have a good experience. So let's flip the table to the stories that I got on the weekend from the nurse practitioners and the paramedics that were in that mobile bus that was at Mumford. I don't know where it's going this weekend. I think perhaps even going out to Cobequid. The providers on that bus walked away on air. And you talked to some of the minister, but they were so happy to provide frontline care very quickly, very efficiently. People were happy. Like, it just was a really good vibe. And I want that vibe for you in your day job. But maybe we will need to find ways that you can be on the mobile bus, or you could be doing virtual care, but something that gives you a bit of a break, I guess, is is what I say, because it's not all money. I can pay you twice what you make, you're still going to be in the same boat in terms of work-life balance. So it's a balance between financial and other ways to help you realize your value to us.
And I would just add, I think, the complexity has changed so much, and we need to change, to the point about the collective agreements. Some of them have pre-existed. They've kind of been extended or negotiated when we were 9 district health authorities, and now we're 1. And just some of the barriers that's created around the collective agreement. So I don't want it to be cliche, but the past is not the future. Like, we really need to be innovative and understand how to support our workforce. Recruitment is a retention tool as well. Like, once we fill those vacancies and there's not so many, the travel nurses, which, to your point, they are necessary right now in order for you to have a safe work environment. But we essentially want to work those folks out of business so that we have our own engaged workforce. And we need to talk to staff, frontline staff, understand what will help them. What are some of the things that are really grinding, right? Some of the things that are really grinding. So it will take us some time, but we are very focused on retention as well. And, we want to improve your quality of life as well as make sure that you're fairly compensated.
And I know we have one, I'm very cognizant of the time right now, so we are at 4:00. And I know you have one more comment. Is it a comment or a question? Is it?
If you put it in context for the Black nurses, it is 1,000 times more, because it's not about just the work-life balance. It's about the whole piece of inclusion. And we're talking about inclusion, we really have to take a different lens to see what does that look like for Black nurses, not only for retention, but for access to school, and many other things. So I think for me, I'm going to wind up, I'll be very quick, I know we're over time. So there are 3 things I want to say. The first thing is we really and truly have to look at inclusion from a broader perspective. And we have to look at it from the structural determinants of health with all the policies and the barriers that Black people have faced for all the many years. And we have to figure out how we do that. And that is institutional from a system perspective, that is at academia in the university level, that is also at the school levels. And so we really have to address those. And it's important to have the Black students come in to learn, but we have to go deeper than that. That is a good first incentive. We have to figure out from the system level, the whole system level, we have to figure out from the university level, the challenges and barriers that impact the Black nurses or Black people accessing to that. That's the first thing. The second thing, very quickly, is the IEN. We have IEN nurses that come into this country who are master's prepared, baccalaureate prepared, and what are we doing when we assess them? We are putting them at a level to go and do the CAA training or the LPN training. That is devaluing and that is disgraceful. So we have to fix that. And the third thing is about leadership, right? Leadership in all the other places, we don't have Black faces. And it's not because they don't have the skill set and the competencies. We still have the colonialization, the systemic barriers where we pick and choose and cherry pick. We have to figure out, if we are talking about EDI, what does that look like from a concrete perspective? It's not a token gesture. So you have done some great work. You are on the right path, but we need people who have had the lived experience, who can really guide the process, and who are at the table. I often think sometimes I may have to take my chair to be at the table, invite myself, right? But we have to take a different pathway. You are doing fabulous work, and you have opened up the doors. Hawks is doing fabulous work. But we need to have a voice because their lived experience. Rose has 43 years experience as a nurse. I have 48 years, and I don't know how many other people have experience. Healthcare is something we know, we live. And it's not just the scientific piece. Many people in the communities can tell you how they care and provide services with their own treatment, traditional treatment. We have to start thinking about that. So that's all I'm going to say.
Thank you very much. I think that's a great way to end this discussion today. And again, I want to thank you all very much for coming out. And I every time we do these conversations, I say this. I think it's so impressive to see the community come out in whatever community we're in and talk about the issues and the concerns they have and to bring solutions forward. And also to this leadership team that will come in front of a group and be willing to take those questions and answer those questions. And thank you to them. I will also say, for anyone who has questions, that still has questions, I know that we are at time and we are going to have to go. Make sure you write them down on a card with your contact information, and we'll make sure that you get those questions answered. So thank you so much for coming, and well, you'll be in touch. Thank you.